most important thing about this slide here is that I have no financial disclosures, unfortunately. Nobody wants to pay me anything. And so I'm going to be talking on the intumescent and brown cataract. This is not moving. This is not moving. Okay. So, yeah, that's my first. You know, the regular white cataract, which is not intumescent, there's nothing great to talk about it. All you have to do is, you know, stain the capsule and go ahead and do your regular phaco. Nothing much to talk about it. And now, but in the Morgagnian cataract, again, in these cataracts, you are not going to get the flag sign. So you don't have to worry about that. The problem comes with the milky cortex, which obscures your view a bit. That also you can manage. And when you do the disassembly, you will get fragments which are not supported by any epinucleus. So they can fly around. So you have to handle those. Now, the main thing that I am going to come, oh, can I have the audio, please? Sorry, I have to go back. Because there's no point, you know, if they don't understand the joke. Can I have the audio, please? Sorry, I should have told you before. Put it a little loud, no problem. Okay. Yeah, thank you. Yeah. So, what I am going to be basically dealing will be when you are in a situation like this. Yeah, when you get the flag, that's a horrible situation, okay? And before I actually go into ways of dealing with it, I'll just go with and talk about some theory behind. This is, of course, some clinical cases of the flag. Sometimes you can get it right when you puncture. Sometimes you can get it even after the double rhexis when you have done. And this theory actually came from Brazil. So with aging, you get two chambers forming. Because of hydrolysis of the cortex, you get an anterior compartment and a posterior compartment in front and behind the nucleus, coupled with a formed equatorial cortex at the periphery. Now what happens, these are two pressurized chambers. Now you go ahead and decompress the anterior chamber. Now the unhindered pressure from that posterior chamber behind the nucleus will push the nucleus up, and this will cause the tear. This is the theory behind, okay? So there are various methods of dealing with the flag. I will, however, deal with only a few of them. So first you can put a heavy duty tamponer and then do your rhexis underneath. In the second slide you can see on the far right is I'm putting a B hex, and I believe this B hex can actually press down on the capsule and limit extension. That's my belief. And you can do a manual decompression when you take a 26 gauge needle, aspirate the cortex and decompress the lens. This is very difficult because you are having both your hands on the syringe and you are pulling on the plunger. So it's very difficult to control. The movement when you are pulling itself can cause the flag. And this is a very good method. This is a double rhexis wherein you do a small 2 or 3 mm rhexis, decompress the lens with either a Simcoe, you can see my overused Simcoe there, and or you can use a bimanual aspiration, decompress the lens, scallop the border and go ahead and make a sizable rhexis for your phaco. Or you can do what is called a snail track rhexis. That is, you create a small tag at the periphery of your rhexis, and that tag you keep spiraling it out to the required size. The logic behind this is that you can control a tag better than you can control a flap. So this is also a very useful method. Now this method, you can go with the phaco itself, punch a hole into your anterior capsule, and with the vacuum itself decompress the lens. Then either you form a tag, or with the tag that is formed, go ahead and fashion your rhexis. Now, but my go-to technique is the automated decompression. Now, what I do in this automated decompression is basically my decompressing needle. I attach it to the aspiration line of my phaco machine. So my left hand is free, my non-dominant hand is free to either fixate the globe or inject visco. So this is the technique. See, you watch this. This is just a regular IV set. You take that anterior part, that's a lure connector. Remove that housing around that lure connector. Then you get two connecting ports. You see that? So one, you attach it to your aspiration line of the phaco machine, and the other one, you attach it to your decompressing needle. Whatever needle, you can use any needle, 19, 20, 21, 22, 23, 26, but I prefer 24 gauge. So what are the advantages of this technique? As I told you, it is connected to the phaco machine. So you are not pulling on a syringe and causing any movement. You're very stable. Your non-dominant hand can stabilize the globe or inject visco from the side port. And your vacuum is coming, mind you, not from your hand, but from your foot switch. As you're pressing down, the vacuum comes in and you decompress the lens. And this is just some examples of different gauges. And you can see that last one, the 26 gauge. There also you can get a very good decompression of the lens. So you can use this thing. But as I told you, I prefer the 24 gauge needle. Now coming, and frankly speaking, even if you get the flag, it's no big deal. You can handle it. Just do a crude rexus and do your phaco. Just to show you that even in the event of a flag, you can manage. Now coming to my next topic, that is the brown and hard cataract. Please, these principles are very, very important. The most important principle is you have to be calm and you have to be confident. If you're not confident, don't attempt this case. Okay, so basically your preparation should be very good. You have to have a good block. If you're doing under topical, you have to have good counseling and a cooperative patient. You have to have a very well dilated pupil, good anesthesia, stain always, no matter what the red glow is. Do a large rexus. Do a minimal but effective hydrodissection wherein you can rotate the nucleus and break all the capsulocortical adhesions. Now, when you are doing the nuclear disassembly, use any method that you prefer, but please break that backbone. Okay? So, whenever you are separating, you have to see the red reflex. You have to see the posterior capsule. Okay? And stay as far away as possible from the endothelium. You can even, mind you, you can even use HPMC. Although they say soft shell technique, who does soft shell technique in this country? Who has Helon in their theater? So even with HPMC, you can go ahead, but you eat the nucleus in the back maximum at the iris plane. Do not come into the anterior chamber. Okay? And the most, OVD is very important. Every time keep refilling. As Uday Devgan and everybody says, endothelium is expensive, OVD is cheap. So you keep on refilling OVD. Okay? No, don't be shy about that. And the most important thing is you have to stay calm, focused, you have to be methodical and confident. And this is the same thing I'm just showing you. You have to have a good block, perfect incisions, stain your capsule, well dilated pupil, do a largish rexus, please, a largish rexus. Do a hydrodissection, rotate, remove the superficial cortex and that OVD, because OVD can be thermogenic. Please remember that. And these are my settings. You can have any settings. And when you're chopping, look for the red reflex and do a multi-level and migrate centrally so that you break the backbone. And many times you have to watch for that posterior plate, posterior movement. It will move this way, moves this way. That means you know the backbone is broken. Do not do a flower petal type of disassembly, because you try to bring it into the anterior chamber, you are going to have corneal edema the next day. Okay? So with these principles, you can handle any hard cataract, but you have to be confident. And you can see here I am refilling the OVD. Rotate that to a accessible area. Don't try stunts by bringing it from behind your probe. And when you are taking out the segments, try to hold it by the apex of the segment. That is the best place. And the number of segments has to be minimum 6 or 8 or 10. Do not do 4 segments in a hard cataract and try to take out large segments. You will use a lot of energy. So with all these principles, and do not forget about the, having done the hard part, don't forget about the cortex. Remember, these are very progressed cataracts, so the zonules will be weak. So take your time over the cortical management, remove all the OVD. When you're putting the IOL, remember you had a large rhexis. So you have to make sure that your foldable IOL is in the bag. All these principles work beautifully when the cataract is hard and brittle. So you can chop. But what happens when the hard cataract, especially in diabetics you must have seen, is attached by a backbone? You can chop. It will still be attached in the center. And it makes it very frustrating, as you can see this, trying to break the backbone. And it can be really, really frustrating when you can't break it. So what I do in this situation, what I do is when I have the attached backbone, I flip the nucleus over. This looks scary, it can be done, but should be done by only experienced surgeons. Okay, you flip the nucleus over, attack that attachment anteriorly. It breaks up into pieces and you can easily emulsify. That's real time. It goes in very fast. It will go in very fast, but you need experience and you need skills in SICS as well. You can also do this without flipping with the Sensky hook, like this. Just with the phaco probe. See, I'm holding on to that piece. I keep holding on with my vacuum. It keeps coming in and the whole thing flips on itself. And I will reach the backbone. Once I reach that backbone, it will break into pieces. Now, when you are doing these procedures, be very careful, because once you reach the center, the whole thing will split up. You'll get 8 pieces. So if you're not careful, these pieces can fly around in the anterior chamber. Make sure you keep it down. So refill AC if you have to from the left hand. Don't allow the pieces to fly around in the AC.
Yeah.
And with that,
So what I believe you were trying to say is thank you.
Thank you.
You're welcome.
thank you very much.
So that was a very elaborate and good presentation where you have actually taken care of where actually the beginners will have trouble, and that doing a capsulorhexis in white cataract and having a Argentinian sign is something which everyone is afraid of, because now more and more premium IOLs are going. So that tip and your newer tip of just irrigating and taking out the fluid was very good. And also the method of just not doing the petalite pattern, but just going through 4 and or 5, 6, 7, 8 quadrants which you talked about was very good. And these are all the points which should be taken into consideration. Thank you.
Any questions to Dr. Sunil Tangaraj?
Any questions? Everybody is looking at my face, but they're not asking me any questions. Okay. Who's talking next?
Dr. Satyajit Sinha is not here, so will be
This one is, next is
managing small pupil.
during cataract surgery.
Yeah. Dr.
Right.
Sujeta Parisa.
A very good afternoon to all of you. Sir has actually made some of my things easier to speak on. I'll be talking on managing small pupil during cataract surgery. I have no financial interest in this presentation. So when we are dealing with any cataract, we never want any small pupil to be there. Now what poorly dilating or non-dilating pupils are indeed a challenge for cataract surgeons. So beforehand, if you know, if you have done a meticulous examination, so you know you are dealing with a cataract which is a small which has a small pupil due to a lot of causes, so then you can prepare yourself. But what happens when you have an intraoperative meiosis? That is where it is very difficult. So we come to a question of size of the pupil, which is the critical size or optimal size which we say as a small pupil. Is it 2 mm, 4 mm, 6 mm or 5 mm? Now this also depends on the surgeon's skill. Now if a very expert surgeon is there, he can again perform a very good phaco without taking care of any devices into the thing if it is also a 5 or 4.5 pupil. But for a beginner, they have to be very careful. Anything less than 5 they should not attempt. They should take the help of other devices. What is important also to remember is two things: whether your pupil you are dealing with is an elastic pupil or a rigid pupil. If you are dealing with an elastic pupil, then putting any pupil expander devices will come into play. Otherwise, if it's a rigid pupil, you keep on putting your devices, it will tear. You will have a iris tear, then you can post operative you have glares and you will have problems. So which type of a pupil you are dealing with? So it's IFS, mostly it will be a elastic pupil, so you can stretch those pupil and we'll just go about. So what are the steps? Now I am going to talk about what are the causes. We always think what are the causes of why there will be a small pupil. Well, we know PXF is something old age or a diabetic patient or a IFS patient. So this you are already prepared that these patients will be having a meiosis in the intraoperative period. So you take care of armamentarium of your pupil expanders or iris hooks. But if you say that the pupil was very well dilated and still you had a problem intraocular, what are you going to do? First and foremost, we give a intracameral adrenaline in most of the cases. Preservative fee, if it dilates, we are fine, we can go ahead with our phaco. If not, you should be having a high elastic visco devices with you, mainly Hilon. If not, also we use same methyl cellulose that can help you. But what also comes into play is your pupil expanders. So small pupil, what next? So if you are dealing with a uveitic cataract, how much you stretch them, you have to be very careful. You have to do a synecholysis in those cases. If still the pupil is not dilating, again you have to do a fibrinolysis, means you have to see whether there is a fibrin over the pupil. So just stretching it will not help. So or you can give some visco, which will be showing you that 3.9 will become dilated with a viscoelastic. Now what next are you going to do? If initially they were doing multiple sphincterotomy, but you can also try a pupil stretch pupilloplasty. These are mainly helpful in cases of rigid pupil. And then we have a lot of pupil expanders, and which one you are good at, you can do it. So let's start with one of my cases. This is a patient who you can see was a patient who was under tamsulosin for some 3 years, and the patient was dilating well. But what I have cut short this video to show you that intraoperative there was a meiosis, and then I had to take the help of the iris hooks, because iris hooks usually it's better if you have a expander BX with you, but if not, at least everyone has a iris hooks, and this also helps you to stretch the pupil. And so that what is important is you can do a good capsulorhexis, and if you are dealing with a premium IOL, at least you can see, or a toric IOL, you can see where you are keeping the IOL in the bag. And then how do you put in the iris hooks and how do you take out, that is important also, because that should be in parallel to the iris plane. So next we have with us pupil expanders. So it's starting from Malugan's ring to BX from Soven Bhattacharya, who has done it. And then we have this ABX, that is from Dr. Asia's, which is it's a very good, you can put it in 2 sides and it stretches the pupil, and just very easy, it's like a clip thing, and you can do it also. It doesn't have much of a learning curve in this cases. So next patient, let's go to the next video. So this was a toric case which I was doing. So if you see, it was a good dilated pupil, but what happened, you see that the pupil, even giving a visco dispersive, it was not dilating fully, and then I have to see fully, and you can see the pupillary roughness that was still safe. So it's not going to dilate with any viscoelastic. So I had to put in a pupil expander, do a rhexis, adequate rhexis, and once you are having your adequate rhexis, you don't have to worry, because you are able to see and you can do a good hydrodissection and then go about with your phaco. Very important in this cases, if you have a hard cataract, you should be always doing it in the plane, don't bring it to the AC because we never want the endothelium to get damaged. So I'm coming to another case. So this is again a uveitic cataract. Now how much we have tried to do a pre-operative dilatation with atropine, and still there are multiple synechias. So I went about to do a synecholysis in this cases, but what you can see is that even after doing a synecholysis, the pupil was still not expanding because there was multiple synechia in these cases. So you do do a full 360 degree still and see how much is the size of the pupil. Now once I did this, so this is what was the size of the pupil which I was getting. So could I get about with this? Well, no. And then I was very clear that this is a uveitic patient. I cannot risk without giving this a thorough in the bag IOL in these cases. So after this you don't have to worry because it becomes like a normal case, and you can do a rhexis and then go about putting a intraocular lens. So you have to be very thorough in these cases. You have to take out meticulously all the cortex, and then you have to see, because you have to mark this is a toric, and you have to mark properly, and in small pupils you won't be able to see where actually you are placing the intraocular lens. So there are a lot of studies if you see, and we have some of good studies from our side, and like management and outcome of small pupils in cataract surgery. So two things are very important when you are dealing with a small pupil because of uveitis, or are you dealing with cases of IFS. So first case was the IFS case which I showed you. You should be very careful, because sometimes what happens, even during the surgery, a very good dilated pupil can have meiosis, and once that meiosis is there, you start all the complications if you don't have a proper dilatation and managing the cataract accordingly. So we have with us a lot of pharmacological agents, devices, and then lot of changes in stretching mechanisms. And to conclude, pre-operative assessment helps in to plan and anticipate your case and how to prepare yourself for surgery. Pupil expanders are Xavier's. What to use? If you are actually dealing with IFS, it's better to use a pupil expander, but if it's a subluxated cataract and small pupil, it's better to use the iris hook in this cases. Thank you.
Thank you, doctor. That was really elaborate, very well done. And probably for completion, you have, for juniors especially, you have all these fancy expanders, but I would suggest that you please be very well versed with your iris hooks. That works in any situation, in every situation. So, and iris hooks, okay, some people are very fussy about how the sphincter tears happen and stuff like that. If you're very careful, it doesn't happen. So be very, it will get you out of anything. So all the other pupil expanders, they have a fixed size and sometimes are very difficult to, and they have extra instrumentation, and sometimes difficult to, you need a learning curve to use them. Iris hooks you don't need. There is only one other Canabrava iris pupil. See, there's one place where you cannot use these expanders, other than iris hooks, I'm not talking, is coloboma iris, because you don't have it as a complete thing. So all these expanders are, but there is one expander called Canabrava expander, pupil expander. It's a PMMA expander, and you can use, it's like, it goes in like, it's something like that, like a CTR, and it's got these hinges, so you can even put it in a coloboma iris. So just keep that in mind. That is going to come out. I hope it will be inexpensive. It doesn't need extra instrumentation. It needs nothing. It needs a McPherson forceps and a Sinski hook. So it's a very good technique. So otherwise, doctor has mentioned everything. And yeah, when you are doing in a small people, obviously your confidence matters. If you can do. If you can't, that's the worst thing you can do. You will get a lot of complications. And now the next speaker is Dr. Rajesh. He's going to, sorry, any questions? Yeah, please.
Use the mic, sir.
Huh?
Phenocaine, intracameral phenocaine, your experience.
Yeah.
It's very good, sir.
Yeah, phenocaine works very well.
It's very good. It works very well.
Huh? No, if the pupil is not going to dilate, it's not going to dilate. So that's out. That's out. Tonic pupils, it's not going to work. But rest, suppose you are not dilated properly. Or suppose you have an angle closure glaucoma. See, normally angle closure glaucoma, you don't want pre-op dilation because he'll go into an acute, especially if he doesn't have a PI. So what I do is I do my incision, put in phenocaine, dilate on the tape. Now you have your incision is not going to go into angle closure. So that's where phenocaine works. And with all IFS, you're going to use intraocular midricaine or you're going to use phenocaine. It's a good option.
Any small pupil, first try with phenocaine. First try with that. It doesn't work with that. Go ahead with the other thing.
First try with viscoelastic. Put in viscoelastic. That itself will dilate the pupil.
And
Yeah.
yeah,
Yeah.
and
If nothing, at least a vial of adrenaline will be there in everyone's
There are some contraindications for
some
adrenaline.
adrenaline
So that's a
can't
problem.
can't be really used in hypertensives and all. There are some reservations for that. Even like in mid of your phaco, the pupil comes down. First, put some phenocaine. It will dilate again. That should not
Can
be.
you put adrenaline in a PCR? Can you put adrenaline? Suppose the pupil shuts down. You've got a PCR and it closes down. Will you put adrenaline?
Adrenaline, epinephrine, adrenaline, they are known to be toxic to the retina.
Not only that, there is a case that the patient goes behind. It got CRAO. Can cause a central retinal artery occlusion. Be very careful. So take this as a message. If you have an open capsule, do not use adrenaline, please, especially if you have vitreous loss. Do not use adrenaline. Okay? So just keep that because you can be in trouble. So I think we'll go ahead with Dr. Rajesh.
Thank you very much. It's a pleasure to participate in this midterm on the AIOS conference at Vizag. And I'm Dr. Rajesh, and the topic given to me today is difficult phaco made easy. I'm going to take a different approach. Of course, my friend Dr. Sunil, my friend Dr. Pavan, Dr. Neha, Dr. Sucheta, they all can tell you what exactly can be done. I mean, like what steps to be done, how to do it, and everything they have cleared. They'll clear the things to you very clearly. How did they achieve this capability of doing these cases and recording them and then presenting them to him? I am going to take you through that process. There are some common difficult situations for phaco, like the hard cataract, the small pupil, the shallow anterior chamber, corneolopasties, cataract with secondary glaucoma, zonual weakness, posterior polar cataract, stiff neck, uncooperative breast. Stiff neck is a very difficult situation to manage. So my approach to this is having these 9 P's. 9 P's is having a good preoperative assessment, plan how you're going to do your surgery, ponder about it, analyze about it, like analyze the risk factors, analyze the pros and cons about it, and practice your steps. Procure the equipment, the necessary equipment that you need to handle that particular case. Have a peer group. Your friend Chalpati is working in your own town. You talk to him how he dealt with those cases. Have a group discussion. Perform the case properly, preach it to your staff, preach it to your students, and then present it in conferences like this. So do a very good, proper, thorough preoperative assessment. Even though it is seen by your other consultant who is also very good, it is always wise for you to personally reassess. This is what I want the surgeon to do it. You should always reassess your own difficult phaco case. See, mostly. What do you call a prolific surgeon like Dr. Pavan, he will not be seeing the OP himself. Somebody else will be seeing the OP, and he will be seeing the patient for the first time in the theater. No, you should be seeing whatever complicated case is there, a difficult case is there. You should be able. You should assess yourself. For example, you go and look for any phacodonosis, go and look for any zonular dialysis which may be missed by your other consultant. Assess the depth of the anterior chamber, see what else is necessary, check, very most importantly, check for the dilatation of the pupil, etc. Then plan your surgery. Sometimes you may have to rearrange your plans. Sometimes you may have to do your side port incision first and then go for the main port. Small things. So plan your steps of the surgery. You may have to modify your steps, make a note of what you want to do, and you have to do the proper rearrangement of the self, and then ponder over your steps, analyze them, look for at the risks involved. You're going to do maybe you're going to do a secondary glaucoma case that has a cataract. So you may have a chances of an expulsive hemorrhage. So you should know what are the risks involved of giving an incision. You should analyze that. See if you're doing the good to the patient or not. See if you're making the things worse for the eye, and make changes in your plan. See what you can do better. Then all you need to do is, even for the as you know, even the best athlete in the world, he needs to do some warm-up exercise. He needs to do some practice every day. In the similar way, practice your steps of surgery and do a virtual run through of the steps in your brain. You can just close your eyes and say, okay, I'm going to first give a side port incision, only then I'm going to put visco through the side port, then I'll do the main port incision. You go through a virtual run through of all the steps in your brain and make a list of the instruments that you'll need. Then you'll know, oh, I will need a special instrument for this. You will have make a list of that and inform your staff about it, about the instruments. That is more important. You should inform them and then tell them to make them ready. If the instruments are not there, procure them. Make sure that all the necessary equipment are ready in your OT, and check for any special instruments that are necessary, and procure all the dies, glues, CTR, segments, hooks, etc. well in advance of the surgery date, and make sure that all the special instruments are sterile. This is very important. The other day I had to go to another. This is exactly what has happened, and an example which I have given you on the right hand side. I've ordered for new IA tips from the Olcan company, and I went straight ahead to the theater. The representative thought that whatever is given new by the company is sterile. He said, I asked him, is it sterile? He said, yes sir, it is sterile. Then he is luckily I have taken it. I checked it before before scrubbing, and I have noticed that he has handed over a tube to me, and he said there is a tip inside which is sterile. How can this tube be sterile? It is not sterile. So had I washed and gone into the theater, and after then I realized that it is not sterile, I am in the middle of the surgery and I can't finish that case. So I had sent it to the autoclave, made it sterile. After 1 hour, I started the surgery. So this is very important. Always make sure that all the instruments that you need are sterile, because these are the instruments that you're not going to use it regularly. You put it aside, and the staff brings it to you. Make sure that they are sterile. Have a peer group discussion. Talk to your friends. Discuss with your friends how to deal with the difficult situation. Take their inputs. Watch some videos. Read some articles about it if they're available. And then you can do it. You know that you can do it best. You do your best of your surgery, and while doing your surgery, do not take any shortcuts, and follow all the protocols meticulously, and follow your surgical plan meticulously, and record your surgery and review it later. This is very important. You have to record it. Only when you record it, only when you review it, you can preach it to your juniors and to your students. Not only that, you have to tell about this to your staff also, because they need to know about what you're going to do. Only then they can assist you properly, and present them in any of your clinical staff meeting, or any CMEs, or your town's professional meet, or your state meet, or your national meet, or if it is a good case, an international meet. This is very important. Only then everybody will come to know how to deal with that particular situation. Only then we know how Dr. Sunil Tangraj deals with all these hard cataracts, and Dr. Sucheta deals with all the small pupils. This is very important. Thank you very much. This is how we can make all these difficult factors easy. Thank you.
Thank you, Dr. Rajesh, for that. This is very important. All the points that he said are very important. I mean, you too often, what I see is, we forget that we work as a team. We don't bother about our paramedical staff. We don't bother about our nurses. We take everything on ourselves. It's not good. It's not a good habit. You have to make sure that your team is running through all the drills. This is what I was talking about yesterday also. Suddenly you get a PCR, you want to do a vitrectomy, and most of the surgeons do not know how to connect the vitrectomy. I can guarantee you that. Almost 100%. They will not know how to connect. They are dependent on the staff. Now that guy has done the connection some eons ago, whenever you had it. And then you give him the tubes, he doesn't know which end goes where. So this is very important. So you have to run. I always make sure I check my cutters, I check whether they know. Other things very important, please, it's not related to your ophthalmic surgery. I don't know how many people of you are having this. Do you have an ambu bag in place? Do you have a defibrillator in place? Do you have all the emergency medicines in place? These are very important. Are you checking the expiry dates? See, probably if somebody arrests in my theater and if I try to resuscitate him, whatever little chance he had is gone. It's probably gone. I think so. But at least you should have things in place. So that's what he went through. Very nice talk, and think about it. And now the next speaker is Dr. Pavan. Dr. Pavan. He's talking on tips and tricks for mature cataract. Audience, if anybody has any question, feel free to interrupt. Don't worry about, you don't have to be polite. You can interrupt. I mean, be polite to us. Be polite when asked. You don't have to curse us, but yeah. So, but if you have any doubts, don't keep it hidden. This is what I find with many people.
Yeah,
they are
please.
very shy
Please
to
use
ask
the mic.
questions.
Please use
Please
the
use the
mic.
mic.
Let everybody hear it.
If you see the Argentine sign and how to prevent that extent behind the equator.
Very good question. How many Argentine flags have you seen going beyond the equator? Zero. Most of them do not go beyond the equator. Almost all of them never go. They stop short of the equator. You know, when it goes beyond the equator, it's when you are trying your manipulations, especially during nuclear disassembly. You try to do nuclear, that is when you have to assess your skills and your confidence level. If you have a hard cataract with an Argentine flag and you are trying to do nuclear disassembly in the bag, that's a very bad idea. Because the nucleus is large, so when you laterally separate, you are going to propagate the tear, especially if the tear is inferior. If it is horizontal, it is not so dangerous. When it is inferior, it can just sink. So assess that. So hard cataract, what I would say, if you're very confident of doing a supracapsular phaco, which is very risky to the endothelium, go ahead. Otherwise convert to SICS and take it out. If it's a soft cataract, you can do it in the bag. You can do it in the bag. You have to still be careful. And soft cataract, frankly speaking, you can bring it supracapsularly and take it out. You're not going to, with reasonable technique, you're not going to damage the endothelium. So I hope that has answered your question. So Argentine flags, you don't have to worry. It doesn't extend when it happens. Okay? And you cannot, there is no way you can prevent 100% an Argentine flag. Whatever the method I showed, you are going to get it. Okay? So that's important.
Good afternoon, everybody. As my seniors, Sumil sir and Rajesh sir has mostly discussed about managing mature cataract, I have a very little left to talk. So I regularly emphasize that we have to do a very good slit lamp examination for all the cataract patients to assess the grade of the nucleus, whether the patient is having pseudo exfoliation, chamber depth, grade of the cataract. And specular microscopy is another important thing that you have to do in a case of mature cataracts, because if there is a low endothelial cell count, you better change the procedure. You can go for a manual SICS, which is safer for the patient. And B-scan is another investigation that you usually must do in case of mature cataract patients to see whether there is any fundus pathology. And other eye fundus examination is also very much important in case if the other eye is operated. If both are mature cataracts, then B scan will do, and A scan you have to go with an immersion to get an accurate IOL reading. And this topic is already much discussed, and this thing, and I think so manual dilatation is also discussed much, so I'll just go with a few techniques in Rexis, that's all. And in Rexis, as sir told us, you can go start small and spiral it out. You have better control in doing Rexis in this cases. You start small and spiral it out. And in other scenario, when you have rhexis that is running away with when you start doing with a cystotome and you lose control of your rhexis, you can always use micro forceps, rhexis, capsulorhexis forceps to complete your rhexis. And in the next scenario, when you have very small rhexis, then you can still extend your rhexis intraoperatively by using a micro forceps, micro scissors to cut an edge of the rhexis and then extend it with micro trata capsulorhexis forceps as shown in this video. Even if you get a small rhexis, just do not panic. This is just for the beginners I'm talking about, and you can use that micro scissors, have a nick wherever comfortable position you can manipulate the rhexis. Then even then, if you feel it's still small, you can still extend it, and you can still cut it and extend how much ever size you require. And coming to a total phacoemulsification in a soft white cataract is not a difficult case, but in a hard white cataract, I usually follow a stop and chop technique. I usually do a trench from equator to equator, and in this, as told, diabetic patient, it's very difficult to crack the posterior spine. So what I do is I crack the nucleus, and if the central part doesn't crack, I just do not overstretch the posterior capsule. I don't do overstretching it. Instead of that, I go to the place where the crack is already there in the equatorial portion. Then I just crack that, and then easily it cracks off, and once you eat that that part of the nucleus, you get adequate space to crack the nucleus, other parts of the nucleus, and crack the nuke completely. And this is this technique, after Sunil sir told me, I'm afraid to present like this is a patellar cracking. In this case, what happens, this is a very large nucleus. So what we do is I centrally debulk the nucleus first to decrease the density of the nucleus, and then do as many peripheral cracks as possible. 360 degrees I crack the this is a diabetic patient, and this patient the cataract is very leathery. I was not able to get a crack. I tried, but I couldn't. So instead of creating any complications, I cracked it all over 360 degrees. I created a peripheral cracks, and as I debulk the nucleus in the center, I start pulling the peripheral petals towards the center and eating it inside the bag itself. I didn't prolapse the nucleus outside the bag. And be generous in using OVDs while doing these cases, so that you protect the endothelium and other ocular structures. And in the end, you can still crack the nucleus, or you can take as the nucleus volume is totally reduced, you can just hold it with your phaco probe. The nucleus posterior plate tends to fold, and you can easily finish your phaco in this kind of cases. And this is another hard leathery cataract, where, as previously described, I trench, stop and chop, a little bit modified stop and chop technique, where I trench the nucleus in the between from equator to equator, and as I told you, when I crack, I usually don't overstretch the nucleus. So wherever the piece is cracked, I go to that portion of the nucleus, crack it, and slowly eat the nucleus from that. You can get the fragments easily phacoemulsified from that point. So my take-home message is always don't panic on large or hard nucleus. You have to have a surgical plan how to deal with the nucleus. As discussed earlier, if your pupillary dilatation is not adequate, you have pharmacological dilatation and even mechanical dilating techniques and all. And phaco technique, what you follow is always dependent on your maturity level, your experience, and it can go with anything, but always keep in mind to have the best interest of the patient. So not your ego must not be satisfied. So even whatever you do, you have to have best results for the patient. Thank you.
Thank you.
Thank you, Bhavan. That was excellent, actually, looking into your dexterity and the control and balance which you had. That is very important. And also for the beginners, now when you are driving a car, you know everything about your car. It's similarly, when you are sitting for a phaco, you have to know certain parameters, how you are going to deal, because you are the one who has to maneuver the nucleus and everything then and there. And if you have seniors, it's fine for you to help you around, and the best interest will be on the patient's outcome. That is very important points. Thank you. So we can call upon the next speaker, Dr. Chellapati Reddy, who will be speaking on visual outcomes and post-operative complications in iris claw IOL, our experience from Kurnool.
Good morning, everybody. I've done this work at Kurnool Medical College, Kurnool, and my other co-authors are Dr. Lata and Dr. Udayshri. And coming to the introduction, in the bag IOL implantation is the basic standard of care in cataract surgeries. As you all know, you have seen a lot of scenarios where you cannot implant a lens because of poor capsular support, or because of paraoperative complications like PCR and other complications. And these things can put you in a soup, and you may have to leave the eye phakic. And such situations you can get away with by putting an ACIOL or a scleral fixating IOL or a retrofixated iris claw IOL. And SFIL has been extensively studied, and now we know the advantages of putting a scleral fixated IOL. But we have also seen some complications like suture-related complications, cystoid macular edema, decentrations, and pigment dispersion, all these things in SFIL. But ACIOL became little unpopular because of endothelial decompensation and other secondary glaucomas. And now the knowledge regarding retrofixated iris claw lens is limited, especially in our Indian eyes. We have done this study to know the intra and post-operative complication and visual outcomes with retropupillary iris claw IOLs in aphakic Indian eyes, either primary or secondary. On the table also, if you have a complication like PC rent or a zonal dialysis, you can still manage with putting a retrofixated iris claw IOL implantation. And this study has an institutional ethical approval also. And the methods of the study are, we have consecutive 67 eyes in the last 1 year, and ours being a training institution, we have a lot of PGs and trainees doing cataract surgeries, and we do come across these complications like PC rents and zonal dialysis most of the times. And we are doing primary anti-vitrectomy with iris claw IOL implantation in the same sitting, and only 11 out of these 67 patients we had a pre-existing aphakia where we have done the secondary retrofixated IOL implantation. The inclusion criteria being aphakia due to any of these reasons, and the exclusion criteria being a patient with decompensated corneas and other comorbidities like diabetic retinopathies and optic atrophies were excluded from this study. And pre-operative evaluation, like uncorrected best visual acuity and corrected visual acuity was measured, and intraocular pressures and retinal evaluation has been done. And then in case of a biometry, definitely biometry has to be done. And in case of aphakia, we used to take the biometry of the other eye, and also the same eyes the refraction into 2 into 0.1. We are taking into consideration. And surgical procedure is for retrofixation, retropupillary fixation IOL. You need a regular tunnel incision, either superior or temporal incision, depending on what is you are doing, what you are doing. And then in phakic emulsification, we may have to convert to, we have to suture that wound, and you make a smaller incision, or you can extend it by 5.5 millimeters and suture it at a later time. And all you need is a 5.5 millimeters incision, and you have to make two parallel side port incisions at 3 o'clock, 9 o'clock position if you are going from a superior entry, and 6 o'clock and 12 o'clock position if your tunnel is on the temporal side. And then the IOL is these modified artisan IOLs are a little vaulted, such that it will not be touching the iris. So you have to put it in the inverted way into the anterior chamber first through the. Sorry, I'm extremely sorry. Into the anterior chamber first, and then after thorough vitrectomy, and after thorough vitrectomy only, you have to put your iris fixated IOL into the anterior chamber, and then constrict the pupil before that by using intracameral pilocarpine or carbacal. And then with the Shepherd's iris claw holding forceps, iris claw IOL for holding forceps, you take the one haptic of the lens behind the iris and lift it against the iris plane, such that you will see the contour of the haptics apparently through the iris, and from with a enclavating rod or a Sinski hook, you can through the side port you can enclave it, and then you can do the similar thing on the opposite side with your hands exchanging the instruments. You can do the other side enclavation also after centering the lens. And in all cases the procedure was completed with creation of superior peripheral iodectomy. Iodectomy, I said superior, but in case your IOL is vertically placed, then you have to do the iodectomy at a different site, because at the enclaving sites you should not do iodectomy. And in patients with lens subluxation and IOL implantation was preceded by lensectomy and anterior vitrectomy. And during your procedure, if you have a nucleus drop, better and you cannot take out those pieces, it is better you suture the wound and let vitreoretina surgeons take over that, and you don't do all these maneuvers. And if the nucleus is taken out and if there is only vitreous in the antechamber and you have PC rent and you cannot implant a lens in the PC, then you can go for this type of procedure. And post-operatively we have used moxifloxacin and prednisolone or dexamethasone in most of these cases. And these are the certain scenarios which you can see. The first one, a patient with aphakia and post-operative 2 weeks with a distorted pupil. Small ovalization of pupil will be seen in most of the cases, and which will come round over time. And this ovalization has nothing to do with it, but sometimes because during the primary, as a primary procedure, we did the that side, you can see some cortex behind the PA, you can see some cortex. Those patients need secondary cortical matter aspiration, otherwise you will end up with complications like iritis and glaucoma. And immediately post iris claw lens implantation, the pupil can be round sometimes. And this is that same case where we had that see, the pupil dilatation is also good because you are enclaving at the mid periphery of the iris, so the sphincters are not spared, and you can have a good dilatation like that. And we can do anti-vitrectomy and remove the remnant cortex what was left behind. This is in a patient with an iris claw IOL. Residual matter was there because it was a primary procedure. We couldn't see that leftover material, and the pupil, you see, it was round after the end of the surgery. And post-operative evaluation into follow-up was done for 2 months in the first post-operative day, first week and the first month and second month. And most of these patients had a good visual outcomes of about say 6/9, 6/12. In elderly patients, the outcomes are little different from the younger age group, and the vision was nearly normal in all the groups. And coming to this, iris claw IOL implantation is an effective method of correcting FAK in the absence of capsular support, and several studies have demonstrated this to have several advantages and fewer complications. And it's easy to learn for most of the anti-segment surgeons. It is easier, and no cumbersome suturing, glues and other things. And complications of ACOL like corneal decomposition is relatively less because we are putting the lens in the same anatomical plane like the native lens and furthermore, the retropupillary implantation has recently become popular because now we are not putting in the anterior chamber. Earlier, anterior chamber worst iris claw lenses were put in the anterior chamber. Now we are putting it fixated, so our endothelium is well protected. And post-operative complications that occurred in our study are AC reactions, and 1 or 2 cases we had vitreous hemorrhage also. So few patients had raised IOP, and which was controlled very well over time, and that has come down. And this vitreous hemorrhages and other things, corneal edema, AC reaction has controlled with medication only. And only one patient had a trauma post-operatively where that lens got disenclaved. It is difficult to get disenclaved, but this one particular patient, probably the enclavation was not good and it got disenclaved at one side, and we could enclave it well, and the post-operative outcomes are good. And in conclusion, the effect of anterior claw lens on corneal endothelium has created a physiological barrier to the use of iris claw lens in general. But in view of in our technique, SFIOL insertion is more comfortable and vitreoretinal for vitreoretinal surgeons. But in our experience, we can do retrofixated iris IOL well within the skill sets and manuals are familiar to the cataract surgeons. And all you need is you should have an emergency tray in your kit, and you should have only 2 extra instruments. One is an iris claw holding forceps, shepherd forceps, and the other one is an enclavating rod. you don't use Sinski hook and iris repositor to do that, because it will really chafe the iris, and you might cause injury to the iris. And you should avoid it in irregular thin iris and neovascularized iris, but otherwise it's a safe procedure. And you all should try this retrofixated iris IOLs yourself, and 5-6 cases if you do, and you will become good in that. And for me, because ours being a training center and we have a lot of PGs doing, we do have come across these complications every day, and we have resorted to, earlier we were putting ACIOLs, now for the past 1 year in about 3,000 cases we have about 70 PC rents, and that numbers are good, 70 in 3,000 cases, because we have 10 PGs year on year, and we have 30 PGs doing the surgeries, and we do come across it. But we are promising the patient, we are getting good visions post-operatively also. So keeping that in mind, our experience showed, but thorough vitrectomy and peripheral iodectomy is a must, and you have to follow up the patient for a longer time, because secondary glaucomas, we did had 3 patients of secondary glaucoma, and 1 patient had this remnant cortex also, which we have to take care. And this
sir,
is
thank you, sir.
procedure.
Actually, we are lacking in time,
Thank you.
we can take the question afterwards.
Fine,
There is
fine.
still one more to go. So I call upon now Neha Sudhakar to talk on dealing post-operative complications after cataract surgery.
Good afternoon all. I am not a cataract surgeon. After seeing Dr. Pawan doing, I can say I have not even graduated. I'm a retina person here, just dealing with the complications of cataract surgery. As I can say, being a retina person, I don't have 100% retinal attachment. So I think even a cataract surgeon also has that right to say that I don't have a 100% success rate. So there are complications, and I think the way you deal with it is more important. So either you are a high volume surgeon or you are a fresher or a learner, you will have these complications. Both of us can have. So what you have to do is first stay calm, identify the cause, and then act. Always talk to your patient when you have a complication. So I have 7 minutes, so I'm going to rush through 7 case scenarios. This is my first case scenario, a case operated the first day post-op. This is what happens. So you don't know what this is. It could be TARS, it could be endophthalmitis. So how do I know what it is? So this is how you can differentiate whether it is an endophthalmitis or a TARS. So you have to look for the signs. First is onset, whether it is on day 1 or 2 or a little later. Then look for lid edema, look for any pain, whether they have any pain or not. Look for visual acuity. More important is the corneal edema, limbus to limbus. You have fibrin and hypopyon in both the cases. Then look for vitreous. If you can't look for vitreous and you can't look for fundus, always do a B scan and always check for B scan whether there are any echoes or retinal involvement or vitreous involvement. That is very important. And then you can put them on steroids, and there's a marked response if it is a TARS case. Why does a TARS happen? It can happen because of many reasons, and these are few of them, where you use Trifan blue because you use OVDs. It could be per se because of contamination of intraocular lens. More important, what it is look for patient characteristics like type 2 diabetes or renal disorder patient, and also look for surgical instrument wash. How are they washing? What are they using? Are there enzymes? The ultrasound cleaning baths, ET wood, sterile, all these are very important. Nowadays in today's scenario, a lot of intracamerals are being used, so you have to look into the company which you are using and make sure you are using a good one. It is always good to have even a TOS prevention protocol, like how you have an endophthalmitis prevention protocol, because if you have a lot of them, then it would be a problem. So always develop a cleaning guidelines for your surgical instruments. Always develop content and schedule for routine training of your staff, and also review how they're doing it and look for any new cause for your TARS infection. So how do we manage TARS? We either put them on topical steroids, and it is always good practice to put them on a combined usage of antibiotic if you're not sure enough if it is a TARS or endophthalmitis. There are few delayed cases of TARS which are even seen. So this is one of the case I can show you. So this is a case 2 months post-op with corneal decompensation and is fibrin and reaction in the eye. So this is how we did. After controlling the inflammation, we have done a combined surgery where I have placed a SF5OL. It is a VRS technique. So we just make tunnels on either side. Finish doing a complete vitrectomy. I always prefer doing a complete vitrectomy in these cases. So this is why we exteriorize the, this is how we exteriorize the haptics, and then we tuck them into the tunnels. And then followed by this, I have my cornea surgeon who could just do and finish it with a dissect. So this is how it was dealt with. So there are also cases of delayed tasks which has to be kept in mind. This is my third case where this is how the patient presented to me, operated elsewhere, aphakia with 2 pupils. So this is a large iridodialysis. So the easy way to do is a sewing technique. Just have a clear corneal stab incision, a side port here, and then make a scleral tunnel on the side of iridodialysis. Because of paucity of time, I'm just showing you one how we can move it around. So you take a 26 gauge needle bent, you pass it through your iridodialysis, and through the clear stab side port you can take 9O or 10O prolin. It is a double end prolin, so you have 2 needles, so you just have to pass both the needles from the side port, and you can just take it onto the other side. So you will have 2 ends on this side, and you can just tie it up like how you routinely tie a small thread. So this is how you can take, and your dialysis is quite repaired well. So this is how it is corrected. Small iridodialysis, they have spontaneous reattachments. If you have large iridodialysis, then it needs surgical repair because they have lot of photophobia. And these are the case 4 and 5 I've combined. If you see something on the retina like this, and if you see something on the retina like this, I think what you should do is do less, that is much better. So just clear the wound of the vitreous. You can use triamcinolone to clear the vitreous from the wounds, then do a good anterior vitrectomy, suture all the openings, talk to the patient and send them to a retina person, and please assure the patient. Fishing out, I think you should do it only on your vacations. Then we have the next case where a patient comes like this. Your motto has to be that you don't end up your patient in this way. How do we do it? So you have to dealing with a case of endophthalmitis. So an opportunity is like a biscuit. If you keep dipping it for a longer time, then it gets delayed. So I'll just run fast through so you are a cataract surgeon, you have endophthalmitis. If you don't know how to deal it, then take a support from your VR person. Always how we deal with all our diseases, I think you should deal it in the same way, like how we have learned in our PSM, like primary, secondary and tertiary preventions. Primary prevention is, as you all know, you have to look for all the infections, rule out all the infections. There are no contact procedures on the day. And then this is important, you should know how long the povidone has to be there. If it is on the skin, it has to be for 3 minutes, and if you're putting it into the conjunctival sac, it has to be for 1 minute. Then antibiotics, there's no strong evidence, but people are still using it. And intracameral antibiotics have quite a role nowadays. You also have to look into diabetes, it is very important, more so with the patients who have DR. Then I think this is also important, which we look very less into. This is your OT, where you see your instruments are not crisscrossing. It has to go from sterile. It has to, once it is into sterile area, it has to go into OT. Once they are dirtied, I think they have to go to the CSST. So the rotation of instruments has to be in a single way. You cannot crisscross your instruments. That is one of the major cause of endophthalmitis. These are few things you can check in your OT, which is very important. And if you think you don't have a laminar OT, it is always good you have a regular schedule to clean your AC compartments and the walls of the floor. And also look into these new techniques where we clean the floor, the 3-bucket technique, and also the sampling methods. And hand washing, everybody, all of us know how to hand wash, but the adequate time when we have to do it is for 3 minutes. And also you have to check your water for microbiology. Then this is one important thing where we don't look into. These are few of the indicators which you have to use when you're autoclaving. This will ensure that you'll not have endophthalmitis. They are physical, chemical and biological indicators. So go back and check if you have all 3 indicators are being used or not. Then secondary prevention, you know the endophthalmitis has happened. Now you have to early diagnose it and then control it. So you see a case like this where very mild vitreous membranes and you're confident enough to do with it, then I think it is an early post-op end-off. You can just give an intravitreal injection. So this is like buying time. So just inject. What do we inject? You can give a coverage for gram positive and gram negative. That is either a Vanco and Cefta, good enough. And if you suspect fungus, then you also can inject a voriconazole. So this is a case who had a simple 2 doses of intravitreal injections and would improve from 3/60 to 6/18, avoiding a surgery. So how do you know that patient is improving? So there has to be a visual acuity improvement. There has to be lid edema decreased. You have to look if there's pain gone and all the anterior segment and posterior segment findings are getting better. So this is a tertiary prevention, which I'm going to skip because this would be done by a VR surgeon. So if you can't do anything, you have to plan a pars plana vitrectomy. So send the person at the earliest to the VR person. This is the last case where case can like this after a post-op cataract surgery can present with, and this is a cystoid macular edema. Most of these cases go away with topical steroids and NSAIDs, but they have to be put for a long term, probably for around 2 to 3 months of steroids is required. So don't taper them faster, and most of the cases will do good. If they can't, then I think you can have intravitreal depot injections. This is the other way. If you think you can't afford an Ozurdex, this is how you can do. This is a suprachoroidal triamcinolone, where you can inject the triamcinolone into suprachoroidal space, and it does quite well. Thank you.
Thank you, Neha, for elaborating of which is the dreaded complications for all cataract surgeon, that is endophthalmitis. So we are coming to the end of our session of difficult situations in cataract surgery. And any questions or anything, it can be taken by the individual surgeons, presenters. And due to lack of time, I think more questions we cannot take, and we'll close this session. Thank you all. So we can take a group photo.